late for the presentation because it's being a long day for you. Thank you for organizing committee and for Dr. Hani Badahdah for his organization and inviting us to be a part of this good conference. So, I have nothing to disclose. My objective will be introduction, definition, biomechanics of the foot, type of amputation, and the indication of different type of amputations, decision-making of amputation, diabetic foot, and operative techniques. So, in introduction, annually we have over 1 million patients with diabetic mellitus. They end up with amputation. The burden of amputation in diabetic foot, it's not only for the patient himself, it's also to the healthcare system as well. If we speak about the patient in diabetic foot requires subsequent amputation within 12 months from initial amputation, despite the level of amputation, 25% hospitalization among individuals with diabetes, it's foot-related problems. So 40% of them requires more amputation and requires further amputation for their problem. 45 to 85 of lower limb amputation can be prevented if aggressive and corrective plan followed properly. So definition of amputation. Amputation, as all we are know, it's the amputation of a segment through a bone or through a joint. Major amputation, it's if we cannot preserve the tibial weight-bearing stump, this is major amputation. Minor amputation, if we have weight-bearing stump, is preserved. So, in the biomechanics of the foot, it's very important in diabetic patient because the foot is very complex. It has more than 26 bones, 33 joints, and over 100 muscles. Foot has a particular forming of arches which help to fit even on an uneven surface. So, any alteration in the biomechanics of the foot, it will lead to further problem. So, DM affect the foot and this architecture, as we mentioned, in form of chronic sensomotor neuropathy, foot deformity, callus formation, limited joint mobility, and high plantar pressure and autonomic dysfunction. All will lead to foot ulceration. So, the concept of partially amputated foot is imbalance is critically important. So if we lose an tendinous attachment through amputation, it will lead overpowering of one side over the other side, which will lead to foot rotation, valgus and varus deformity of the foot, and further problem re-ulceration, and end up with more proximal amputations. So our aim of any treatment to deliver a fully mobile patient back into community with reasonable biomechanics to prevent re-ulceration and further amputation. So this is type of amputation in general. Will focus on the minor amputation, starting from the toes, ending up with more proximal amputation like Chobart and Simon amputations. So indication of major amputation, the below knee amputation if the infection is extending up to the ankle or the patient have non-reconstructible fizzles, gangrene involving heel that not salvageable with flap, we will consider below knee amputation. For above knee, if we can preserve stump more than 7 centimeters below tibial porosity, we will consider the above knee amputation. Patient is bedridden or patient failed below knee amputation. Patient has infection extending up to the proximal leg. So regarding the raised amputation, it can be partial. There is amputation if the gangrene or infection involving one or more toes, infection extending up to the metatarsal level, significant tissue loss. TMA, if we have involvement of the forefoot with infection, ischemia or puncture wound leading to severe infection, presence of gangrene of 3 metatarsal to preserve the biomechanics. So if we see one amputation for one raise, especially for the lateral side of the foot, it will not lead to more impact on the foot biomechanics. But if we do the hallux amputation, raise amputation, it will have big impact because more than 60% of the biomechanics of the foot is regulated by the hallux. So this is the different level of amputation. as we see, toe amputation, transmetatarsal, toe part and less frank amputation. So in making decision of amputation in diabetic foot, so we will consider that do we really need to amputate, or as Dr. Maram has mentioned before, is there any other chance for arthroplasty or partial amputation for the toe, or I have to go aggressive for more proximal amputation. So choosing the level of amputation is mainstay of treatment, but the timing of surgery is very crucial and important. Establishing indication is paramount to consider the contraindication. If the patient has inadequate blood supply, it's contraindicated to go for conservative amputation, because that will lead to fail for the wound healing. So toe amputation or disarticulation, it's ideal for wounds that's in the distal toes or the mid toes. So partial or complete amputation of the toe can be performed. Any incision that results in tension-free coverage of the transected bone can be chosen. The simplest technique for complete amputation of the toe is based on racket incision. So for the first and fifth toes, we'll consider to orient the racket medially or laterally and related to the metatarsal head. For the second and third and fourth, we'll orient the incision longitudinally along the dorsal aspect of the foot or of the digit. For partial amputation of the toe, transverse or vertical fish mouth incision can be made. A flexor will consider to remove all tendons, exposed tendon, not to be at the edge of the wound, because it will hinder the wound healing. So cut the bone desired level, make sure there is no sharp object in the wound edge. If this articulation desired, go through the capsule. There is some literature recommend to take out the cartilage because it has poor blood supply, and some of the literature said it prevent osteomyelitis as well, but we recommend better to take part of the cartilage, and because it will delay the wound healing. Limit use of electrocautery because it's small organ, so it will lead to ischemia. Weight bearing is completely prohibited until adequate healing is observed, because as we see in our practice, many patients coming walking after an extensive surgery of the foot, so it's recommended to be completely immobilized. So this is the example for the incision which we made for the toe amputation. So this is example for some cases done along with Dr. Hani Badahdah. It's very good cases. This is distal toe amputation. This is distal phalanx amputation. And this is distal phalanx amputation. Raise amputation, it's amputation of the toe along with the metatarsal head. So same incision will be made, but we'll modify the racket by extending the handle of the racket to provide sufficient exposure of the shaft of metatarsal. Extensor tendon divided at the edge of the wound. Shaft of metatarsal can be transected with power saw 30 to 45 degree to preserve some biomechanics of the foot. So stay close to the wound, to the bone to avoid injury to the arteries and perforators. Sesamoid bone are excised, flexor tendon are transected under tension to facilitate retraction. Near normal foot mechanics can be achieved after amputation, as we mentioned before, except the hallux, because it will lead to big impact on the biomechanics of the foot. So this is example for the raise amputation. Just don't forget to take the ulcer with you if there is any ulcer in the plantar or dorsal aspect. So this is example for raise amputation for the hallux. This is example for second and third toes amputation. This is example for fourth and fifth toes amputation. So team May, it's have good outcome in form of healing, biomechanics, and rehabilitation. It's preserve the length of the limb, normal shoe wear. In severe infection, consider do it as 2-stage, not 1-stage surgery. It's contraindicated if there is a rear foot or mid-foot deformity. So incision across the dorsum aspect will be at the metatarsal heads. Of the plantar aspect will be at the base of the toe, making a fish mouth incision. Remove all the tendons slightly proximal to the shaft of metatarsal of the edge of the wound. Divide periosteum just proximal to the metatarsal head and metatarsal transected using sharp saw. So one thing that the transected metatarsal should be incurved, like starting from medial to lateral aspect, with difference about half centimeter between each other, 3 to 5 millimeter between each other, with the plantar oriented cut, so it will preserve some biomechanics during the lift off. Excise flexor tendons and sheets and the cartilaginous structure, deflate, tourniquet, achieve good hemostasis, irrigate and close into layer. Some consider Achilles lengthening to prevent equinus deformity of the foot. This is the example for the incision. This is one picture for Team May. Finally, Les Frank, it's rarely done. So only some technical points that all tarsometatarsal joints are disarticulated, except the second metatarsal is divided 1 to 2 centimeter distal to medial cuneiform, and there is modified Les Frank procedure which preserves the base of the fifth metatarsal at the insertion of peroneus brevis. The Achilles tendon is released as well, because as we mentioned, to prevent equinus deformity. The plantar fascia is sutured to the periosteum. The skin is approximately interrupted or interrupted monofilament suture or staples. So this is example for Les Frank. As we see, we preserve the base of the fifth metatarsal and part of the second metatarsal bone. So this is picture of Les Frank procedure. Thank you very much. I'm sorry.